Hello, and welcome back to the clinical case series. I hope you're enjoying everything that you're learning so far and really taking the time to learn these concepts and apply these concepts in your office on a daily basis. Whether it's improving your diagnosis or improving your treatment skills, this class is for you. If you have any other cases you're interested in discussing with me, sign up for that clinical mentorship program. It'll really help you dive in and help you understand and flush out ideas in terms of diagnosing and treatment planning complex interdisciplinary cases. Today's case is connective tissue grafting with a coronally advanced flap. Do you struggle with diagnosing and treatment planning mucogingival defects, or do you struggle with referring these types of cases over to a local periodontist? Well, then this case is for you. So sit back, relax, and let's dive in on this quick tutorial on connective tissue grafting and coronally positioned flaps and how I suture these types of cases. This case was referred to me by Dr. Kevin Snaer, a local pediatric dentist in the San Gabriel Valley, more specifically, Arcadia, California. He's been practicing in the area for over 30 years and is a wonderful pediatric dentist. So if you have any children who need pediatric dental needs, give his office a call. You'll be well taken care of. Let's dive in. So Kevin referred this case over to me. A mucogingival defect on tooth number 3, with the localized facial recession and early furcation involvement. This is a kid who is approximately 18 to 20 years old. I can't remember the exact age, but let's look at this case. Let's look at the clinical photograph and let me draw on this and let me show you what I am seeing. First off, I want to take note of the mucogingival junction, that junction between attached tissue and movable tissue. The next thing I want to know is the recession, and the recession relative to the other adjacent teeth. So let's highlight where that free gingival margin is on tooth number 2 and tooth number 4, and this will help me explain how much root coverage I'm going to get with the patient. Here is the free gingival margin on tooth number 4. And here's the free gingival margin on tooth number 2. So if we extend that line across, I would expect to gain about 80% root coverage, maybe 90 relative to the adjacent teeth. There's a little bit of the exposed root still remaining. The other thing to take note of is when you're trying to understand how much root coverage to gain is where is the papilla? And is the papilla filled inapproximally or is it not? If that papilla is filled inapproximally, there is likely bone within 2 millimeters of the CEJ. In this case, there might even be a little bit of altered passive eruption, so I would assume that the bone is approximately 1 millimeter from the CEJ, given how short the clinical crown lengths are. So just things to be mindful of when you're looking at this case. The other thing when it comes to treating these cases that I need to be mindful of is what does the bony architecture look like? Is there a big bony ledge 2 or 3 millimeters from the start of the root? Or is it really flat? This will help determine whether I'm going to take a tunneling-based approach or a full thickness flap-based approach. So all things to consider. There's different classification systems when it comes to these types of cases. Just know I like to use the Miller classification system. This is a Miller type 1 recession defect. The other thing I want to be mindful of is how much attached tissue is actually remaining. Remember, we have our sulcular depth of about 2 millimeters or so, and the remaining attached tissue is less than a millimeter in this case. So these are all things to be mindful of in terms of how much attached tissue is there and how much attached tissue is needed for gingival health. So the goal of therapy for this case is twofold. I want to gain root coverage and I want to increase the gingival thickness from an average biotype to thick. So I'm going to gain more attached tissue, and I'm going to gain some root coverage on this case, if not 100%. But let's look at this case and let's look at my incision design for this one tooth mucogingival defect on tooth number 3. Interestingly enough, because of the bony ledge and the bony architecture that you can see right here, these cases become challenging to tunnel and work our way from coronal to apical without tearing the papilla because I have to put a lot of pressure on the tissues to get my instrument over and around that bony ledge. So with a Langer and Langer approach, or 2 vertical releases, you can see here a beveled incision, increasing the surface area for tissue to become attached. And then the papilla will be deepithelialized either with a 15 blade or a round burr, a diamond round burr to deepithelialize. This allows me to get one, good access to the furcation. 2, you can see this cervical enamel projection. So I'm able to plasty out that, and I'm able to roughen up the root surfaces with a diamond burr, flatten the root surfaces, and then I'm going to treat with EDTA to put those microscopic porosities into the root to further allow for epithelial attachment and Sharpie's fibers attachment. All things needed for a predictable result. So let's see how I sutured the connective tissue graft before closing. So you want to stabilize your graft underneath your flap prior to closure. When it comes to a one-tooth defect, the area that I like to harvest connective tissue is going to be around the tuberosity area, distal to the second molars. That's the first place to look. I like this tissue because it's more dense than palatal tissue. It's more predictable to harvest. Sometimes you never know if you're going to get good connective tissue or more glandular connective tissue on these types of cases. So this was a tuberosity harvested CTG graft with a double blade technique. I use a double blade that's 2 millimeters in thickness to get a predictable, thick, uniform slice. I'm going to remove the epithelium as I've done here. So this is the epithelial part of the graft. And then I'm going to suture this graft and I'm going to stabilize it in a few different ways. First, I'm going to stabilize the corners of the graft into the papillas, extending to the palatal aspect, and then tying that knot through. The most important suture that I put in here is going to be a subperiosteal mattress suture. I really like this photo because it highlights how predictable this type of suture can be. So we make a periosteal releasing incision deep in the vestibule to allow for passive primary closure. When I'm taking the bite for this subperiosteal mattress suture, it is apical to that periosteal releasing incision. Why? This is going to mattress that graft down deep into the vestibule. The sutures that are used here are going to be 5-0 glycolon on an 18 millimeter needle. I like the length of that needle because it allows me to get interproximally, much easier to pick up that needle on the palatal aspect of the tooth. So this graft is well sutured and well mattressed into place. Next, we need to close. So I'm going to coronally reposition that tissue. And in this case, I'm going to overcorrect the issue. I'm going to close it with 6-0 glycolon sutures. So in this case, we have closed our vertical with the 6-0 glycolon. Everything has been coronally repositioned. And again, I'm going to do another sling suture. So that's this suture right here. So I take my bite from epithelium into connective tissue, out through the sulcus, interproximally, around the palatal aspect. And I'm going to take my next bite right here. Again, epithelium to connective tissue, come out intrasulcularly, pass the needle through interproximally, back around. I'm going to tie that suture right here. I want my bites to be at about the line angle, 3 to 4 millimeters from the free gingival margin. What I see people do more often than not is, let's look at tooth number 5 over here, for example. They might take a bite here and here. Well, this area can be a little bit too close. You might limit the vascular supply. So you need to be mindful when you're taking these stitches or when you're taking these bites with these sutures to be broad, right? Kind of more in this area right here where you see the circle and right about here where you see the circle. That'll ensure you get good passive primary closure and you won't limit or strangulate the blood supply on that delicate, thin biotype. So I hope you learned a lot about the learning objectives in this case, my mindset, and just some subtle ideas in terms of how I come across and how I treat recession defects. More to come in other clinical cases. This was kind of a unique case. I don't often use two vertical releasing incisions to treat these cases. My go-to treatment modality is more of a tunneling type approach especially in the anterior aesthetic zone. But it really depends on the number of teeth, the tissue quality, the papilla thickness, the adjacent tissue thickness. All of these issues come into consideration when I am deciding to move forward with surgery. So again, I hope you've learned a lot about this case. I want to thank Kevin Snaer for referring this case over to Arcadia Perio and letting us treat all of his patients with his periodontal needs. So again, thank you for tonight's lecture. Take that 3-question quiz after this lecture, and we look forward to seeing you again. Thanks so much and have a wonderful day.